connect my talk. So, is it okay? Can you see my slides?
Yes, it's clear.
Okay, thank you very much. First of all, I would like to thank Dr. Nabil and organizing committee for this kind invitation. And today I will speak about the recent development in macular surgery. These are my financial disclosure. And I mainly, two topics I will speak today is macular hole surgery and lamellar macular hole surgery. So as you know, 360 ILM peeling is currently considered as a gold standard technique for macular hole surgery. However, the results were not so encouraging in challenging case. In challenge case like large macular hole, chronic hole, recurrent, myopic, traumatic, or pediatric case, and with this technique, we could not get good results, and the anatomic success is less than 50%, functional success even worse. And therefore, during the last 2 decades, many different surgical techniques have been described to treat this group of patients, and some of this technique became more widely accepted, such as invert ILM flap, autologous retinal transplantation, ART, and amnion membrane graft. So ILM, invert ILM flap technique, first described by Michalescu et al. In 2010 as a multi-layer inverted flap. Then different modifications have been published, such as insertion of ILM into the hole, as you see here. ILM is inserted into the hole, or single layer inverted flap. In this technique, ILM is covered the macular hole, but not insert into the hole. And the temporal flap became more widely accepted. In insertion technique, after staining the ILM, we peel ILM 360 and insert it into the hole. And we use PFO bubble to be insert ILM in hole more safely. And then we remove PFO and the fluid air exchange and give the patient 3%, 5% C3F8 and face down position. This is after surgery. With this technique, the anatomic success is really good, but the closure pattern is irregular. We call this W pattern because the ILM into the hole, the ILM layer into the hole, prevent regular recovery of the retinal layers, and this affect the visual results. And usually the visual result is not as good as single layer inverted flap. However, in single layer inverted flap, this patient is operated. This after surgery, you see almost normal macular configuration we obtain with this agent. All the retinal layer can be seen clearly. And we call this U-shaped closing pattern is almost normal macular configuration. In this technique, usually I use small bubble of PFO to close the macular hole area to avoid the dye to the RP and macular photoreceptor for potential dye toxicity. Then temporal crescent area peeled ILM, then the temporal ILM invert into the hole. I use a large bubble of PFO to destabilize the ILM flap as a single flap and smooth and without wrinkling or folding. So this is my standard technique in all macular hole today, and in all sizes of macular hole, I use this as a primary procedure. But for the challenge case, we have some other solution. So with this technique, when we follow the patient a long-term period, we observe some complications such as cystoid change in the fovea. As you see in this patient, this is before surgery. 1 month after surgery, everything is okay, but in 3 months after surgery, we observe some cystoid change on the macula. There's another case, 1 month after surgery. This is 6 months after surgery. You see again significant cystoid change. Also, the ILM is elevated. So we assume that this complication is because of the potential dye toxicity. There might be dye toxicity, and therefore, why is the dye toxicity issue here in this technique? Because unlike 360 ILM peeling, in 360 ILM peeling, we stain ILM and peel all the ILM, but in this technique, we stain ILM in a surface ILM, then invert ILM over the macular hole area, and the dye trapped on the macular hole area and contact with photoreceptor and RP. And therefore, with this technique, we should pay attention to not to stain the inner surface of eyelid flap to be inverted. This is our conventional staining technique. This is our new technique, and we call this selective eyelid peeling staining technique. And in this technique, we use a large pool of PFO only to stain the temporal area where we will start the peeling of ILM, not the inner surface of ILM to be inverted. And as you see here, after injection the dye, usually the temporal crescent area stain, and then we create a flap, and the inner surface of the ILM in this eye is not stained. So then we, after this change, this modified technique, we did not observe any more cystoid change or the other complication. This is the after surgery. As you see, a month after surgery, we obtain very good results, and the macular is completely closed. It's almost normal macular configuration. Also, in this patient, we can monitor the flap configuration with OCT. As you see here, in this case, the flap is perfectly as a single layer stain cover the macular hole area. This is the ILM peeling area. You can see dark spot here. This dark spot is retinal nerve fiber dissociation. We call this retinal dimples. This is a kind of complication maybe, but usually they do not affect the visual recoveries. So the other technique is autologous retinal transplantation, ART. You know, it's described first by Tamer Mahmoud and Grewal. And usually in my technique, I prefer this technique in very large refractory macular hole, as you see here, over 1,000 micron, as you see here. This patient has more than 2,000 micron large macular hole, a chronic macular hole, and this is only one eye. Also, the total retinal detachment in this patient we observe, and also some PVR. And with this technique, the ILM is already peeled in the previous surgery, and we prepare the retinal graft and insert it under the PFO bubble to the macular hole area. And in this patient, we use silicone oil. And this is after silicone oil injection. And this is after silicone oil removal. You see the whole area is closed, and OCT we obtain almost quite a good macular configuration, and vision improved to 0.16. Comparing the previous picture, we obtained very good results. Still, the patient keep this vision for almost more than 2 years. Sorry. However, when we look at the multicentric results, the anatomic success is really good, but visual improvement is not in this patient. Therefore, still is under discussion. This technique is ART is a simple patch or more than a simple patch. So the other technique is amnion membrane graft. It's also became very popular, but the availability of amnion membrane is not possible everywhere, and therefore I do not have any experience in my clinic because it's not available in our practice, and therefore in this challenge case, we developed another technique, and we use another material, this autologous tenon capsule plaque, and we published our first result in retinal case brief report with this technique. And I will share 2 cases with you operated with this technique. This patient has 69 years old. Patient already operated for macular hole surgery, and ILM is peeled, but hole is still open. You can see the ILM peeling area, very large areas, ILM peelers. You can see the retinal dimples, dark spots. And with this technique, first we harvest the tenon plaque from superior temporal, inferior temporal, doesn't matter. Then insert into the vitreous and reduce the size, and a very small piece of tenon we insert into the hole under PFO bubble. Then remove the rest of the tenon from the eye, and then we apply fluid air exchange, remove air and also the fluid and also PFO. Then inject a piece of a small drop of OVD over the tenon plaque, and face down position. This is after surgery, 1 month after surgery. You can see hole is closed. You can observe the
Recording in progress.
As a hyperreflective tissue, but what we observed during the follow-up period, and this hyperreflective tenon plaque gradually resorbed by itself. This is 6 months after surgery, and this is 1 year after surgery, almost is gone. This is, and also we obtained a limited visual improvement, 20 to 400. Another patient, actually this patient we plan to apply this also a peritoneal membrane, to peel a peritoneal membrane and inverted flap, but the ILM is also peeled together with a peritoneal membrane, and therefore we apply tenon plaque as a primary procedure. This is a month after surgery, again a large piece of tenon plaque on the macula, but hole is closed. Again, 3 months after surgery, gradually resorb and reduce the size, and this is 6 months after surgery. Again, we obtain some vision for ambulatory vision for this patient. So comparing the other technique like amnion membrane, ART, this technique, this autologous tenon capsule plug is relatively simple, repeatable, autologous, and easy to achieve, and also easy to locate the tenon plug due to its sticky nature. So it's available everywhere and every time, and therefore it's really, this technique seems to be a good alternative to other filling material, which is more available, more difficult to get the comparing this material. So the second topic is lamellar macular hole. You know, in this topic, in this disease, there are many discussion controversial points. First, the classification. After Govetto classification, you know, Govetto classified this technique as a degenerative and tractional lamellar macular hole. Very recently, in 2020, Huxman et al., with the consensus of Govetto, published the other new classification. According to this classification, this entity divided in 3 groups. The first 2 groups, and they consist of peritoneal membrane, and there is no tissue loss in this 2 groups. One is peritoneal membrane ERM phobiaschisis, and the other is pseudohole. This is a kind of tractional group. The other is lamellar hole, and is degenerative group. Three mandatory findings that we have to see in the patient to see that, to be able to say that it's a degenerative lamellar macular hole, foveal cavitation, irregular foveal contour, and tissue loss. Tissue loss is mandatory. So the other finding is optional. What about the treatment? So first of all, if the patient is stable, if there is no progressive visual loss, no severe metamorphopsia, we don't touch this patient. But if there is progressive visual loss, metamorphopsia, we can apply need to surgery. In the first 2 groups, we can, if there is tractional peritoneal membrane, we can apply conventional ERM and ILM peeling surgery. This is very effective in this group of patients. As you see in this patient, different direction, you can see tractional type of lamellar hole. This is mustache type epiretinal and epiretinal membrane. We apply standard surgery after staining. We peel both epiretinal membrane and inner limiting membrane in this patient as a standard that we are doing very well, and we obtain very good result. This is, as you see here, this is after surgery, and almost retinoschisis almost is recovered completely, and vision improved. However, this technique is not good choice for lamellar or for degenerative lamellar macular hole because of the high risk of developing full thickness macular hole. So this complication reach up to 50% in some series after this conventional ERM, ILM peeling. And therefore, different techniques have been investigated in this group of patients. One of them is epiretinal proliferation or lamellar hole associated epiretinal proliferation embedding surgery. You know, the epiretinal proliferative tissue is around the lamellar hole. This is yellowish, sponge-like glial tissue. And in this technique, we peel this epiretinal proliferation and insert to the hole. And Chiraga et al. Reported very good functional result with this technique. In our practice, we combine this technique with the invert island flap technique. So as you see in this patient, an OCT, you can see degenerative lamellar hole and cavitation. Usually the epiretinal proliferation has negative staining pattern. Any dye stain with this tissue. Then when we peel the epiretinal proliferation tissue, as you see, then stain with brilliant blue, you can see the epiretinal proliferative tissue as a layer on the covering the macular hole area. And after this staining, you see the ILM is perfectly stained where it was not stained before epiretinal proliferation tissue removed. Then we invert ILM over the macular, lamellar macular hole area. And this is after, again, OCT, intraop OCT, you can see double layer of ILM and also epiretinal proliferative tissue flap. And fluid air exchange, this is a week after surgery. We obtain very good anatomic and functional recovery, so vision improve in this patient. This is another patient, again, in this patient, both tractional epiretinal membrane and also epiretinal proliferation the patient has in this eye. And when we apply the bully staining, as you see, the area around the manhole is not stained, but the periphery with tractional ERM, it's stained, and we peel with tractional ERM, also epiretinal proliferative tissue. Then we remove the tractional part of the epiretinal membrane and only reduce the size of epiretinal proliferation. Then again stain, and LM is perfectly stained. You will see after the peeling of this epiretinal proliferation, and ILM is decayed. As you see here, ILM is perfectly stained. Then we apply inverted ILM flap covering the lamellar macular hole area. And this is after surgery. In this patient also, sorry, maybe I can show you. Yeah, this is we obtain collect 17 patients reported with this technique, and Lemonize obtain 3 or more line visual acuity improvement, and all of these are except one at better visual acuity, more than 0.3 visual acuity. So on the other hand, visual gain in eyes with initial ellipsoid zone defect in this group of patients was not good, and usually in this the other rest of the 7 eye there was ellipsoid zone defect, and the pre-op vision was also poor, and the post-op visual improvement was also not good. Therefore, I think the earlier intervention before ellipsoid zone defect developed could be a good idea for this patient to get better visual acuity. So in conclusion, epiretinal proliferation embedding surgery allows us in this group of patients better anatomical and functional results, and also prevent serious complications such as full thickness macular development with conventional ILM and ERM peeling surgery. And restoration of the foveal configuration is not sufficient and to improve vision, and therefore especially continuity of the ellipsoid zone appears to be more important, and therefore we can change the treatment paradigm of this group of patients, and by planning the surgical intervention earlier before easy defect develop in this patient. So finally, I would like to share you with our vitreoretinal surgery book recently published by Springer last month, and you can find all this video in this talk, in this book, and in the book contain 85 videos, and in all vitreoretinal disease requiring surgery, and you can reach the book with this connection. Thank you for your attention.
Thank you, Professor Ramze, for this nice lecture. Our next speaker is Dr. Faisal Fayyad.